Hello everyone, welcome to Mass Coding TV, our Mass Coding Solutions. Today I'm jumping right into where I left off with neoplasm coding. Now, if you missed the first section or segment on this, you have to go back and get it because I cannot go back into review. So let's talk about how do we determine the principal diagnosis in dealing with neoplasm coding. This is key to coding, neoplasm coding. I don't know if some of you all work in the industry, but in our industry now, we go through a lot of audits. We got a lot of auditors out there that will come in, review our work. If you're an inpatient coder, and you work in what we call a PPS system, meaning that you get reimbursed under the MSDRG system, that principal diagnosis is a key driver in where you're going to land in those MSDRGs, okay? And because cancer is one of those ones that can be a little bit confusing to code, we sometimes get way too many denials saying we didn't code it properly. So let's talk about how do I select this principal diagnosis. Now remember, the definition of the principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission to the hospital. Now that's a mouthful, okay? And you know, that you would think that that could have a pretty black and white interpretation, but it doesn't. So anyway, they give us guidelines to help us to know how to take that definition and say, okay, I got this definition, I got this guideline. How do I marry these two? And so let's talk about cancer coding. The first thing we want to know is this. If the treatment, and this is in your official coding and reporting guideline, if the treatment is directed at the malignancy, designate the malignancy as the principal diagnosis. Now, of course, we always have an exception. And you might say, okay, Mary, that sounds good, but what does that really mean? So let's take a scenario. My patient has come in with nauseous and vomiting, dehydration, severe weight loss. So now they're working the patient up. Why is they having the nausea and vomiting? Why did they have the severe weight loss? Why are they dehydrated? And so in the process of working up to find the underlying cause of these conditions, they find out the patient has ovarian cancer. And the physician relates those symptoms to the ovarian cancer. So now, my principal diagnosis is going to be the ovarian cancer, because after study, that is what was the problem. The problem was not necessarily the vomiting, the nausea and vomiting, and the dehydration and weight loss. The problem was the cancer. And so, now, of course, you know, there are always a little bit of exception, so maybe that wasn't a good example. But that's, and let's say they go on, they do a thoracentesis or paracentesis. Maybe they got fluid. Maybe they do oophorectomy. They remove the ovary. So now the treatment is being directed at that primary cancer, and that's going to become my primary diagnosis. Now, of course, you know, we do have exceptions. One of the exceptions is this. If that patient is admitted strictly, and I do mean strictly, for chemotherapy or radiation therapy, they would have that, one of those codes would have to be principal. Okay? In other words, the cancer has already been diagnosed. They already diagnosed it. And now they're coming in for their chemotherapy, or they're coming in for their radiation therapy. That radiation therapy or chemotherapy is going to have to be principal. Now watch out for this. That scenario I gave you where the patient had the oophorectomy. So maybe they do an oophorectomy, or maybe they say, you know what? This cancer is so aggressive and so bad, we're going to do chemotherapy now. We're going to start the chemotherapy now. Okay? Now you as a coder, you got to think that one through. Okay, so we are talking about the principal diagnosis with neoplasm. And we was talking about the dehydration, nausea and vomiting, and weight loss. And the patient has an ovarian cancer. That ovarian cancer has never been documented. All those signs and symptoms are due to the ovarian cancer. And they said, look, we're going to start your chemotherapy before you leave the hospital. In a case like that, ovarian cancer is your principal diagnosis. Because they really worked it up, all the signs and symptoms was related to it, and they had to make a decision to do the chemotherapy. If that same patient, when that patient is discharged from her first treatment, when she come back, and she's coming back specifically just for chemo, then my Z51 code is going to be the principal. So kind of marinate on that, think about that, and how that should work, okay? Anytime your cancer requires some type of treatment, I'm going out on a limb and saying this because, once again, things get misunderstood. There are going to be times when a patient may come in with cancer, never been diagnosed, and they may make a decision that they don't want any treatment, such as a removal of the breast or removal of the cancer, whatever the case may be, but they may decide to accept chemo. Well, in that case, your principal is still that cancer. Chemotherapy and radiation therapy as a principal diagnosis should only be used when you know that you know, or your documentation support that cancer has been diagnosed, and they know it's cancer, and they coming in strictly for the chemo or the radiation therapy. So be careful with that one. Treatment directed at the secondary site. So we talked about treatment directed at the malignancy, of course, and the way they have that worded, you would think A is dealing with the primary, because when you look at B, it specifically says treatment of a secondary site. So there are going to be times when your patient going to come in and the problem is the secondary site, not the primary site. Once again, there can be some critical thinking skills that you're going to have to put in place, because sometimes a patient will come in because the secondary is what causing them to present. Once again, it may be someone that's coming in with a lot of bone pain. They're coming in with pain in their bones, maybe it's the back, and they work it up and they say, oh my gosh, you got a neoplasm, you got cancer in the back. And it's metastatic. Metastatic means it's to that site. So they're saying you got metastatic bone cancer. So now they're going to search as to what is the primary. What primary caused the secondary? And depending on what they do with that primary, it may be your principal, even though the secondary was the driver of them coming into the facility. Okay, we're talking about how when a patient presents with a secondary site and they go on a quest to find out the primary site. And so that treatment now could be directed at the primary site and no longer at the secondary site. So in those cases, you kind of have to look at the guidelines. It says when a patient is admitted because of a primary neoplasm with metastasis and treatment is directed towards the secondary site only. See that little word only? They don't bold it for you. They don't put it in italicized. They didn't highlight it for you. But that word only is key to you making the correct decision. It says the primary neoplasm will be designated as the principal diagnosis even though the primary malignancy is still present. So if that patient is coming in for treatment of only the secondary site, then the secondary site would be designated as the primary. If that patient is coming in, like I gave the scenario, they got a bone pain and they got lower back pain, they go in, they find out the patient got a metastatic cancer to the bone in the back. Now they may go on a quest to try to determine what is their primary. Well, see, now the treatment is not being directly only towards the secondary site. So you got that primary site being involved as well. That B on the treatment of the secondary site, that's really for someone that have already had the primary diagnosis and now they coming back in truly for the bone pain to be taken care of. So you have to think about, that's where your critical thinking skills come in. And you got to look at your entire record to see what is going on with the patient and trying to make the very best decision that you can make. Then they talk about complication, coding and sequences of complication. And they gave us some guidelines that we could follow on that. Okay? Now, one of the complications that we can see with malignancy is anemia. Now, you got to be careful with this one. If somebody has breast cancer and the physician write anemia, can we assume that that anemia is due to the cancer? Now, you can, if that patient is not under treatment with chemotherapy or radiation therapy. And I want to go to the word anemia. Let's go to the word anemia in our book and let's see if we got the word with underneath anemia. Now, I'm using a little bit older book. I didn't bring my newer book with me. So I go to the word anemia, and remember the subterm with occurs directly under the main term anemia. So let's look at that. So I got anemia, I got with, disorder. So I really don't have where it says directly with cancer, but I'm looking. I think we may have to go to the subterm in. Let's see if we go to the subterm in. Now in is kind of crazy. In chronic diseases, it's somewhere in this book here. Iron deficiency, secondary anemia, drug-induced chronic anemia. I got hemolytic anemia. I was looking for the word in, and I may just be overlooking it. Because if we go to D68, due to, I see due to, and I don't see in. So let's look at D68 in the tabular. Let's go to D68 in our tabular. A, B, C, and D. Let's go to D68. Because when you go to D68 in your tabular, I may just have to look that up because is it D68? I thought it was D68 where we had our anemia in diseases classified. Okay, D63. Sorry about that. So D63 is anemia in chronic disease. Okay. And then we also have one where we got anemia in neoplasm. So what I want you to know about this anemia, when we're dealing with anemia associated with what they call chronic diseases, one is malignancy, one is CKD, and one is other. those D63 anemias cannot be primary. So you got D63-0, anemia and neoplastic disease, code first, the neoplasm. So if your patient come in with anemia and they have a neoplasm, then the neoplasm going to go first. But you can't automatically assume that all anemias are due to the malignancy, especially if they're having chemotherapy, radiation therapy. So if I had a patient that came in with anemia and they getting chemotherapy, I'm going to have to ask the physician if that anemia is related to the chemotherapy or is it related to the cancer. So that's anemia. Then we have anemia associated with chemotherapy, immunotherapy, and radiation therapy. If the physician documents that that anemia is due to the chemotherapy, then I'm going to go to my adverse reaction and drug section, and I'm going to code that as a therapeutic reaction. Now, of course, if they document that the patient was given too much chemotherapy, maybe the patient is on oral chemotherapy, they took too much of it at home, then of course I'm going to go to the poison section in that area. And then we have the one where we have management of dehydration. Sometimes a patient will come in, especially if they have had chemotherapy. They may come in dehydrated because they're not eating, they're not drinking. And in that case, only, the word only is there again, only the dehydration is treated. Then the dehydration is sequenced first, followed by the cancer. If you have treatment of a complication resulting from a surgical procedure. Now, of course, this to me should be a no-brainer. If someone have, let's say, a sigmoid cancer, and they remove the cancer, but that patient come back in with a post-op womb infection, of course, post-op womb infection is going to be your principal, not the cancer. So any type of complication resulting from a surgical procedure because the patient had the cancer will not make the cancer principal. It's the complication from the surgical procedure. Then they want you to know about number 4. Your number 4 is when your patient have had that cancer previously excised. Now be careful with this one because once again, if your patient is coming in for chemotherapy or radiation therapy or any type of immunotherapy, then there can't be a history of. Even though they may have removed that cancer, as long as that patient is receiving treatment for that cancer, you're going to always code that cancer code. Okay, you're not going to do a history of code. If the patient is no longer under any type of treatment, the cancer has been eradicated, then of course we're going to do the history-out code. And you got to be careful with this one. It's once again, sometimes physician will document that the patient is being observed, or watchful waiting, as we learning that term. Well, that means that the case, it could mean that the cancer has never been eradicated. It never was removed surgically. It wasn't healed with any type of chemo or radiation or immunotherapy. But you got to be careful with that one because sometimes if you look back through the patient history, and I see this a lot with prostate cancer. I worked on an audit not too long ago where we had to validate some cancers, and prostate was one of them. And what we was finding out is that when that patient come in for the 6-month follow-up or the yearly follow-up, they'll say watchful waiting. Well, does that really mean that you never removed it? And so sometimes, and of course sometimes we would have to, get clarification from the physician because maybe I could look back. I can't code from looking back, but I can kind of look back to help me to determine, especially if you're working as a CDI, a HEMA query brief that they put out in 2019 allows the CDI person to look back at previous encounters to help them to understand what is going on in the current encounter. But I can't code from previous encounters. Every code that I select and put on my chart has to stand on its own merit within that encounter. So we went back and looked, and sometimes the patient had never had the cancer removed, the prostate cancer removed. So they could have been on a watchful waiting for a year, 2 years, 3 years. Sometime we went back and we found out that the patient did have a radical prostatectomy done, and now the PSAs are going up a little bit. And so now they're saying, okay, we're going to be in this watchful waiting stage. We're not going to say that the cancer has reoccurred, because one of the ways they determine that, of course, is that the patient PSA may arise, the prostate antigen, specific antigen may rise. And so they don't know, and some different things could cause that to rise. So they said, let's just watchfully wait it before we do anything, before we maybe expose this patient to more chemo that could make them sicker, or radiation therapy. So always remember, you have to do your homework sometime. Alrighty, well, we just about made it through chemo, and just kind of remember, if they're admitted strictly for chemo, or radiation, or immunotherapy, that's your code. Always look to see what is going on, documentation, because sometimes they coming in and they being worked up truly for the cancer. So you got to have your critical thinking skills on. This is going to wrap up our neoplasm. Now I didn't go through all of them in the official coding guidelines. These are the ones I think could help you the most to jumpstart you into thinking about how to code cancer, especially if you have one on your scenario. What else? Just want to say, look, once again, I'm so happy to be here this year. Look forward to working with you all and talking with you all. Don't forget to follow us on Facebook and LinkedIn and Twitter and www.mascodingsolutions.com. Until the next time, this is Mary Gregory.